Neuro-ophthalmic issues are frequently encountered in people living with MS. Dr. Gabriel Pardo explains why it's important for patients to pay attention to changes in their vision and discuss these changes with their clinician.
The eyes are the window to the soul. They certainly can't reflect emotions. I looked him in the eye and I knew that he was a good man. I saw fear in his eye. If we're sad, they will cry. If we're happy, you will really smile with your eyes. So certainly the eyes are the window to your emotions. I do not know for sure that they're a window to the soul, but what I do know is they're a window into multiple sclerosis. And there are several reasons for that. First of all, because the central nervous system, where the process of MS takes place, is involved in controlling the visual system at a high rate all the time. Most of the information that goes in and out of the central nervous system at any given time is related to the visual system. I am Dr. Gabriel Pardo. I'm a physician, an ophthalmologist, a neurologist, and a neuro-ophthalmologist. And I've been dedicated to doing treatment and research in multiple sclerosis for the last 2 decades. My journey to MS was not directly to that disease. When I was in medical school, I thought about different types of specialties. Eventually, I settled in ophthalmology. I really liked the challenge of the very minuscule surgeries, opening the eye, introducing instruments into it, being able to repair that and then seal it back again so that we can preserve and restore vision. But while doing my training and practicing ophthalmology, I really became much more fond to a little bit more of an intellectual aspect of ophthalmology, which is neuro-ophthalmology. And neuro-ophthalmology deals with the relationship between the eyes and the brain. And it's a very complex one, so complex that actually it warrants a supra-specialty. You can be either an ophthalmologist or a neurologist and become a neuro-ophthalmologist to better understand that relationship. And basically, there are 2 pathways that we need to deal with when we talk about neuro-ophthalmology. The information that comes into the brain, which we call the afferent system, and that is sending information that is going to be interpreted as vision, what we see, but also the control that the brain exerts in the position and the movement of the eyes. And it's a very complex process. So what is vision? Vision is much more than seeing clearly. It's not just that visual acuity that gets measured when you go to the eye doctor and they show you letters at the back of the room and you have to read them. That is certainly a very important aspect of it, but not the only one. When we talk about vision, we also talk about the ability to perceive contrast, what we call contrast sensitivity, the ability to perceive colors, to distinguish between different colors, the ability to have depth perception, to have that 3-dimensionality to vision. We also have to talk about visual fields, the visual fields being whatever falls within your peripheral vision and you're able to see. Whatever falls outside of that, it's never seen by your eyes. Think of it as having a beacon of light in a sea of darkness. And only what falls into that beacon is what you're able to interpret, to see. And then beyond that information coming to the brain and being interpreted, you have to have associations. You have to have other areas of the brain involved, because seeing a face does not just mean seeing a face. You're going to tinge that with emotions, with memories, and then that face is going to mean something to you. It's the face of a loved one. It's the face of a baby. It's the face of someone that you recognize. And that needs to be associated with the areas of emotion, with areas of memory, so that you can then have the experience of sight, of seeing. So you can see it's a very complex process. And it's one that, because of that large representation in the central nervous system, can be commonly affected in multiple sclerosis. And that is why it's so important for someone to MS to understand the relevance of neuro-ophthalmology, of the visual system, in MS. There are different types of manifestations that we have from the visual system in multiple sclerosis. And they're going to affect both the afferent system, information coming in, as well as the efferent system, the information coming out of the brain into the eyes. So the afferent system is responsible for capturing images. The eyeball is essentially a periscope, a camera, that is going to capture that image that it's out there. It's going to bring it to the back. It's going to focus it very clearly in the retina. And the retina, which is the lining inside the eye, is going to be responsible for transforming that information into an electrical impulse. An electrical impulse that is going to be sent through the optic nerve into what we call the visual pathways inside the brain itself, all the way to the back of the brain, in the occipital lobe, where you will be actually be able to see that image. And a damage from MS, either for involvement of myelin or destruction of nerve cells, at any point in time in that pathway can create a problem. One of the most common manifestations of multiple sclerosis is optic neuritis, an inflammation and demyelination of the optic nerve. The optic nerve is made up by 1.2 million individual nerve cells, a whole bunch of them, but we need them all. Those nerve cells come from all over the retina, and they come together to form this bundle, this thick nerve that we know as the optic nerve. It's a very sensitive area where MS can create the inflammatory process that destroys myelin. And when an individual has an episode of optic neuritis, he or she will have very common symptoms, a very common presentation. It usually starts as blurred vision that evolves over several hours, sometimes days, to a much more significant loss of the visual function. You will see blurry, you will not be able to identify colors properly. You might have pain behind the eye, especially if you move your eye to the right or to the left, up or down. It's going to evolve like that for days to weeks, and eventually you might have some recovery. Hopefully full recovery, you can go back to normal vision. But sometimes you won't, and you will be left with a deficit. And this is true for most of the processes that we deal in multiple sclerosis. In addition to the optic neuritis being common, there are also problems with the visual pathways. Once that optic nerve goes into the brain, into the skull, it's going to fan out all the different nerve fibers in their journey all the way to the back of the brain, in the occipital lobes. And involvement of those areas can create problems with the visual fields. My peripheral vision can be affected. So when in optic neuritis we have what we call a central vision, the central part of my vision is going to be affected. When we affect the pathways beyond the optic nerve, we're going to usually see visual field deficits. That means that I'm going to have problems with half of my vision, either to the right on both eyes, to the left on both eyes, sometimes to the outside in both eyes. And that part of the visual field is gone. Sometimes with optic nerve problems, we can also have specific types of visual field deficits that usually affect the central part of the vision. By analyzing the pattern of that visual field deficit, your physician will be able to localize the level of the problem. It's very specific. If we know the roadmap and we look at a picture of the consequence of the damage to that area, we will be able to pinpoint exactly where that problem might be residing. In addition to those problems that we have in the efferent system, we also have problems with the control of the eye movements. In order for us to be able to see a single image, our eyes have to be focusing on the same object. If they're not doing that, you're going to see double. And that process of control of the movement of the eyes is quite complex. Essentially, we have 6 different muscles attached to each eyeball that will control the movement of that eye. To the right, to the left, up, down, even rotating in and rotating out. And the centers for control of those eye movements have to actually be coordinated between both sides. Think about it. If you're looking to the right side, your right eye will be pulling out while your left eye is pulling in, involving different types of muscles to do that function that are controlled by different parts of your brainstem. So they need to communicate with each other in order to be able to move in the same direction, the same amount, and with the same speed, so to avoid double vision. One of the problems that we have in that process, typical of multiple sclerosis, is something called internuclear ophthalmoplegia. That is a mouthful, I know that. So we refer to it as INO. And INO, again, is a very common presentation of multiple sclerosis. And INO happens when we have involvement from inflammation secondary to MS in a pathway, a communication between the two different centers of control of the eye movements that represent the right and the left eye in doing a specific movement. So whenever an individual with an INO wants to look to one side, say the right side, your right eye will move out properly, but the left eye will not do so. Either will lag behind and will not move completely, or can get there but will do so at a lower speed. And when the eyes are not coordinated, then you're going to see double. And that again is a second manifestation of the visual system when we affect that pathway. There are other reasons for us to see double. There are some specific nuclei or centers of control in the brain stem that control the different muscles that move the eyes. And when those are affected, you can also have the same consequence of double vision. Those involve nuclei called the third, the fourth, and the sixth cranial nerve. Beyond the problems with movement, sometimes we have involvement of other parts of the central nervous system, the cerebellum, the brain stem, that are going to affect the ability of the eyes to be in a steady position. And they will be jerking. That is something that we call nystagmus. And when nystagmus happens as an adult, which will be the case of the acquired nystagmus in multiple sclerosis, then individuals will have a very hard time focusing because the eye will not stay still. And if you have a jumping image, it will be very difficult for you to be able to perceive that in a clear way. So how do we identify these problems in multiple sclerosis? First and foremost, your history. You're going to tell us what is going on. You have to be savvy about understanding your symptoms and representing those to us in a verbal way so that we can talk the same language. And that is why it's important for you to be educated in these topics. If you have problems with blurred vision, pain behind the eye, and I see certain changes on my examination, I'm going to be guided towards the possible diagnosis of optic neuritis. Likewise, my examination can reveal alteration of the movement of the eyes and will help me localize the problem. But we have even more technologies that will allow us to evaluate the eyes beyond the regular examination. We can do a formal visual field test where we can plot very carefully the entire visual field for each eye and then interpret the results of that. We also have a newer technology called OCT that stands for Optical Coherence Tomography. And this is a technology that allows us to measure the thickness of the retina. The retina is a very, very thin structure, but this technology will allow us to not only measure it, but actually individually analyze each one of the 7 different layers of the retina. We have great interest in the innermost layer, called the retinal nerve ganglion cell layer, because that is the part of the retina that eventually is going to come together to form the optic nerve. So studies have demonstrated that if we analyze the results of the OCT, we can actually get insight into what is happening inside the brain, something that is very important for us when we're trying to monitor the evolution of multiple sclerosis in a given individual. We know that it correlates with the degree of atrophy or shrinkage of the brain that might be taking place over time, as well as with potential disability, not only physical, but also cognitive disability. And this allows us to, in a very non-invasive way, very simple test to do, to have insight into those processes of damage and neurodegeneration of the brain that are very relevant when we're trying to optimize your treatment. What do they mean to you? If we identify those problems, you experience an episode of optic neuritis, if you have a problem with double vision that we can pinpoint to be secondary to multiple sclerosis, it means that your disease is active. It means that we have not fully controlled the process and that we need to optimize the therapy in order to be able to give you a better prognosis long term. They are very relevant in that regard. And what do we do about them? two things primarily. We will decide if we need to intervene acutely, meaning do we need to do something for that specific episode, for that relapse, for that inflammatory process? And if so, we will give you usually steroids to accelerate the recovery process, hopefully limit the amount of damage. In addition to that, as I mentioned earlier, we know that the disease is not fully controlled, and we're going to have to think about what we need to do for the overall management of multiple sclerosis, selection of the appropriate medication so that we can get control of the situation long term. I hope that you will take this information so that you can have a conversation with your healthcare providers, so you can pay more attention to your eyes. Because after all, I do think that the eyes are the window to your MS.